because it is alternate from one side.
Alternate.
Okay, fine.
So
That
I
will be
will
great.
follow GSK.
Okay.
Now, very unstable intertrochanteric fractures are subtrochanteric extension, reverse oblique, extend. Can you hear everybody?
Yes,
Can you hear?
Yeah.
Okay. Extension into the neck, a new variety called as Kyle's fracture, and unstable lateral variety. We have, during the last 15 years, we have had 1,500 cases, and that experience has evolved into 4 principles. The first principle is anatomic reduction with anteromedial cortices, anatomically. Reconstruct the lateral wall and medial wall if needed. Slight valgus reduction is important. And now we are adding a derotation screw. These are the 4 principles that I feel the IT fracture will unite with good function. Now, 2005, Gottfried introduced the shattered lateral wall, a key element in intertrochanteric fracture. It causes instability. Due attention is not paid. Even today, due attention is not paid. Most important factor is it causes loss of initial reduction and reconstruct the lateral wall. Lateral wall reconstruction provides rotational stability, prevents excessive collapse. Now, we treat almost 150 cases per year, and we have studied it. Our study shows what if not fixed the lateral wall. The pieces are loose and are attached to powerful muscles. Every movement of the hip and weight bearing, the fragments move. When the fragments move, it causes pain, inflammation, edema, and sometimes infection. The elderly patient will not tolerate the pain, and therefore he will not cooperate for post-operative early walking. This happens till the fragments become sticky, at least about 4 to 6 weeks. Muscles pull the fragment in different directions, and weight bearing causes displacement, subtle malunion, complications, and even sometimes a non-union. Displaced fragments and muscle pull cause instability. Malfunctioning of the muscles is also an issue. For example, if there is an avulsed greater trochanter, the fragment is displaced upwards and medially, causing abductor muscle weakness, and which causes lurch and a bad limp. Nail buttresses the lateral wall, but it does not fix it. The fragments remain loose. Fixation improves the stability and early union. Patient walks almost the next day without much pain. No inflammation, no edema. Complications are reduced. Our rate of complication was 5 to 10% a few years back. Now it has been reduced to 2 to 5%. Better function. And what is more important is the patient-related outcome is superior. Patient says, I am much better with this. However, all the lateral wall fractures don't require fixation. For this, we need a good classification. With our experience, we developed a classification of the lateral wall. I include GT also in the lateral wall, and therefore the GT fracture has 3 types. One is the tip, very small, which does not require any fixation. The flying GT or the avulsion of the fracture, avulsion of the greater trochanter definitely requires a fixation, and a large GT. Undisplaced, minimally displaced lateral wall fracture, no fixation is required. Burst, shattered lateral wall. Coronal split, there are 2 types. One is the short coronal split, in which it goes from the tip to the lesser trochanter. At the long coronal split extends to subtrochanteric area. Now, banana type, there are two types again. One is full banana, the another is half banana. And the rare sagittal split, no fixation is required. Now, this is the tip fracture, and this is the avulsion fracture with the abductor muscles. This gets displaced proximally, and this requires fixation. And this is the large fragment, and this may not be required fixation because the nail itself buttresses nicely and fixes it to some extent. So the greater tuberosity may not be. However, we are using a lag screw here, not for fixation of the lateral wall, but as a derotation screw. As we use in fracture neck femur, a derotation screw outside the nail works very well. Now today, rotational instability is a big issue. And the solution is using a blade in the PFN, PFNA. PFN has got two screws which also and intertan, and we have using derotation screw, which is simple and equally efficient. This is the small tip fragment, does not require any treatment. This is the large GT fragment. You can see here, this is the fragment here, up to here. And this is the medial wide here, and this was treated with
we have to imagine. I don't think there is a GT fracture.
Yeah, GT fracture I am
Sir,
including in the.
Yes.
Okay. Do you want to see this? Oh, okay.
Okay.
Yeah, there is a fracture there.
Okay, sir, we believe you.
You can see this is the undisplaced greater lateral for. You see, you can see the fracture line here, and this is the one. So this was treated with.
The debate is not about this, no?
No. Debate is yet to start. This is a preamble, I think.
The preamble.
Okay.
Now this is this was treated. The same thing was treated with a screw here. The calcaire screw for rotational stability used percutaneously, for fixing reverse oblique percutaneously, and this is fracture united. Burst or shattered lateral wall. This is the burst and shattered lateral wall. You can see here from here. The whole thing is burst on the lateral side. This was treated with a nail and circulage wire. This augmentation. Now the four principles are observed here. One is the anteromedial fragment is united. Here is reduced anatomically. This is the tension band wire for the lateral wall, and this is the derotation screw, and this is the valgus. These are the four principles that I talked to. This shattered lateral wall associated with a neck femur. This is what is called a Kyle's fracture, and this was treated with DHS and a circulage tension band wire. This is a case I have presented once. This is a burst lateral wall. This lady had a stabular fracture with dislocation and fracture neck femur, IT fracture, subtrochanter, and burst lateral wall. This was treated with DHS and a lateral tension band wire. The fracture united at 1 year. This was at 4 years, and this year she started walking. Now this is a case in which the lateral wall is shattered. Also the medial wall is shattered, and there is subtrochanteric extension. This, we messed up the case. You can see here there is a gap here, and whatever the circulage wire that I have used is not functioning at all. So this resulted into a breakage here. Can you see the breakage here? There is a break here.
Yeah.
and this is the non-union. And this was should have been treated either with double loops or and better circulage wires at two levels. But today we are treating with these such type of fractures, nail and a plate, either laterally or anteriorly. However, in 3 years after coaxing many phone calls, he came back, and to our surprise, the fracture is united, but in a slight varus union. These are another examples of shattered lateral wall. This was again treated with circulage wires and tension band, and so this worked very well. Now this is the another examples. I shall go fast. Now the coronal
No,
split.
sorry, if I can request you,
Ah,
you got to show the end result because you are showing day one X-rays, which is not going to be useful to us.
no, some of them are recently done.
Pardon me to interrupt you.
Okay, okay. I'll show you some of the cases which I have final results. This is a coronal split, which is I feel is unstable, and we need just a screw here. So you can see this has united nicely. This is the final result. And this is the anterior-posterior screw here that I showed you. And this is another example. This is a long coronal. This is what I call a long coronal is, you can just extending to subtrochanter. And this is very unstable. So we need to fix this and note this. This is similar to the case I showed you, the failed case, and this united. You can see the union here. You can see the union. And this is the function. Now, this is another case which is badly shattered with trochanter and subtrochanteric extension. And this is a long coronal fracture, which I feel is very unstable, needs a good fixation. X-ray shows a cavity here like that. And this was again, I'm sorry, this is I asked the patient, has not come because of corona, but he is working in the field. That is what he said. Anyway, this is the one. Now the banana type. Banana type is one in which you will see that the fragment has got a posterior greater tuberosity, posterior wall, and a lesser trochanter. All these three causes there. It's a big. This has a problem is that it is attached abductors and attached. There is a iliopsoas muscle. So abductor iliopsoas muscles, the fragments are moving like that. So you can see here from here, it is a big fragment here. You can see this slight fragment. This one is a big fragment, needs to be fixed. So a one lag screw is all that is required. After reduction, you put one lag screw. So this was treated with a lag screw. You can see this as united, and this is another example of a split. You can see that these patients can walk within 2 days with all this because we have the fixation is good. These banana types are quite not uncommon at all. I see many cases. You can see this. This is again a fracture is united, and this is now this is a very interesting what is called a half banana. That means the banana has fractured into 2 pieces, and this is the problem here is that this fragment is not attached to this fragment, therefore free to move because of the iliopsoas muscle, and sometimes it goes below the head and neck of the femur. So this was treated with this, but again this is needs a follow-up. But now see, this is the case which I told you. There is the half banana which is been.
Sir, can you go back one slide? One, yeah. Here the beak has gone into the medullary canal. Though the fracture will unite, should not be accepted. Just for information, that's all. Yeah.
Yeah, this is what you said. Say again.
The beak of the neck has gone into the medullary canal. This is a cortical support. Yeah.
So there are 2 points here.
Okay.
May I?
Okay.
May I?
You will get a chance later.
Okay.
Myself and Tanna are privileged.
Okay. Now,
team members are not allowed.
Okay. Now there is
Dr. Garikune,
Yes, sir.
if you ask the permission, Dr. Agathe said no.
No. I have
But
made myself.
if you talk, we are not going to stop you.
Break the rule. I will not break the rule.
Okay, come out. Other way around, I am telling you the rule.
Okay, I agree, Shiva. That's a good point.
Negative reduction.
Yeah, negative reduction. Yeah, I agree.
This must have failed.
I think again, I have my objection. We are all seeing day 1 X-rays. We
Not
need
all.
a 6 months X-ray.
I have shown you many cases.
Most of them.
Some of them.
We need the X-ray. I think it is what I have been arguing with Shiva also, with Sushrut also. We show them day 1 X-ray, but we don't show a day 6 months X-ray or 4 months X-ray. Then I think we do not learn anything. I'm sorry, Govind.
Okay.
Please proceed.
I will show you innumerable X-rays, sir. No, don't worry.
Okay.
देखो भाई अभी हम अभी बोलता है
अभी दिखाऊंगा अभी
नहीं वो ठीक है okay sir ये classification नया
carry
है
on Govind.
so it's adding the X-rays now.
Now this piece is, I'm showing the principles. This piece is flying away from the trochanter, including the lesser trochanter, because of the iliopsoas muscle. This needs to be fixed, and this is fixed with a triangular construct here and a circulage wire. Now this is a collinear clamp, a circulage wire passer, and this is how it is done. Yeah, I'll show you a small video of this is the Ganjale has come joined or not. This is from Dr. Ganjale's plate, which he has invented very nicely.
Sir, I would like to interrupt at this stage. Just
see this and then interrupt.
Okay, sure.
This is done percutaneously, the plating also percutaneously, and the whole thing is a percutaneous fixation. Yes, now you tell.
Yeah.
What is it?
So whatever circulage you have passed is essentially to get excellent reduction, good receptacle so that you can pass a nail. So there is no dispute about that. There is no dispute about that.
Right.
We are all fine. Whether to add a plate or not is a question.
Yeah. Okay. It takes 10 minutes, so all methods done percutaneously. And sometimes you get, if you are doing it for the first time, you may get some problems. As in this case, this Mrs. Tortoise, Mrs. Snail, on her first honeymoon day, asked her husband, "Admit it, John, this is your first time, isn't it?" Now we have published our results in injury, and that's worth reading. Our various complications reduced from 5 to 10% to 2 to 5%. Sirs, please construct lateral wall. Patients will worship you for lifelong. Thank you.